Hey, CE Impact subscribers, welcome to the Game Changers Clinical Conversations podcast. I'm your host, Josh Kinsey, and as always, I'm excited about our conversation today. When a patient is facing a serious illness, managing pain and other symptoms becomes a central part of care, and opioids often play a key role in that process. In today's episode, we'll explore how pharmacists can support appropriate, compassionate opioid use while navigating the clinical, ethical, and regulatory complexities of palliative and end-of-life care. And we are so pleased to have joining our episode for today, Lauren Fisher. Lauren, it's your at least second time with me, I think,
Yes.
coming back. So welcome back to the podcast. Um, for our listeners that may not have heard your previous episode, go ahead and take a couple of minutes to introduce yourself. Tell us a little bit about your practice background, your practice setting currently. And I know that this topic is kind of passionate for you. So tell us a little bit how you got into this space.
Yeah, thanks so much, Josh. I'm glad to be back. So my name is Lauren Fisher. I'm a clinical assistant professor at the University of Iowa College of Pharmacy in Iowa City. My clinical practice site is right across the street from the college at UI Healthcare's main campus and our supportive and palliative care clinic. Our supportive and palliative care clinic sees patients with a variety of different types of serious illness. About 80% of the patients that we see are living with some type of cancer, but we also see patients with end-stage liver disease, renal disease, advanced cardiovascular conditions, advanced
Mm,
neurologic conditions as well.
mm.
We do symptom management for those serious illness. So pain management is a big component of that, and obviously our topic for today. But we also facilitate conversations about what's most important to patients in the context of living with a serious illness as well. My previous podcast that I was a part of, we had conversations about aligning medications and providing meaning to medication management. So for those who are interested, I encourage you to take a look at that previous podcast.
Yes. Thanks for
But
that
yeah,
plug. Please do.
yeah. But yes, this is something I'm very passionate about. I've done some research in this area of exploring what types of barriers that patients may have access to opioids that may be prescribed in the context of living with a serious illness, because there certainly are considerations about using opioids for this niche patient population that are
Mm,
sometimes inappropriately prescribed as it relates, or inappropriately considered rather, as it relates to regulatory standards, legal standards, and other considerations, which I'm sure we'll talk more about today.
yeah, yeah. Well, thanks again, Lauren. It's always a pleasure to have you. I know we've interacted in other projects and courses before, but this being the second episode, I'm grateful that you giving us more of your time. So thanks again.
Mhm.
So let's jump into today's topic. As Lauren mentioned, we're going to be, and as I mentioned earlier, we're going to be talking a little bit about opioid use in patients for palliative care. And so just let's kind of set the stage. Listeners have learned that one of the things I like to do first is just kind of lay the groundwork, make sure everybody's on the same page. So let's just talk about just a quick overview, if you will, of opioid use in palliative care. What are we focused on? What are the kind of the overall goals of using opioids in the palliative care space?
Sure. So I think it's important to recognize that for any type of disease state, whether an individual is receiving palliative type care or not, that opioids are not disease modifying medications. Really, what they do is they interfere with the central processing of pain. And so it's important to take that into consideration that the underlying cause of the pain, opioids are not addressing that. So we always want to make sure that we have an understanding of what is causing the pain and that we're addressing that appropriately in alignment of what patients' goals are. Um, there are a number of guidelines out there that outline appropriate opioid prescribing practices. Probably the most noteworthy are the CDC guidelines for opioid prescribing. Individuals that are receiving palliative care, end of life care, or are living with sickle cell disease are actually exempt from these guidelines. And
Hmm.
these guidelines are often kind of the source that drives the creation of institutional protocols, state protocols, and third party protocols as it relates to opioid prescription considerations.
Okay, great. And that is, how often do those guidelines change? Like how often are they updated?
Oh, geez. The last set of guidelines, I believe, came out in about 2022, 2023. And prior to
Okay.
that, they were out in 2016. So
Okay.
was recently revised in the past 2 to 3 years.
Yeah. And I say that just because I think it's important for learners to understand because some guidelines are updated every year. And, it's always
Hmm.
important to stay up to date on diabetes guidelines because they always come out every January, whatever. So
Right.
it's important just to kind of have a better understanding of when the guidelines are coming out just so you can stay up to date. So I want to go back. I heard you say that two sets of individuals are exempt from those guidelines. What exactly does that mean? Like when you say
Sure.
that, what does that mean?
Sure. So essentially, the guidelines are not applicable to those patient populations. And so it is important to consider that what you read in those guidelines, while they are important considerations for opioid stewardship, that those parameters of opioid stewardship, if being applied to any type of like institutional protocol or like a legal sense, that patients that are receiving end of life or palliative care, or if they're living with sickle cell disease, that those parameters of the guidelines should not apply to those patient populations.
And is that typically because we're potentially a little more aggressive with the pain management and the dosing for those patient populations?
Yeah, really great question. So, really, when we think about pain management, it is important to think holistically of
Hmm.
analgesics and what may be appropriate for a given patient situation, other comorbidities that they may have, organ function, but also what is the underlying painful condition that we are treating. And
Hmm.
so, oftentimes in the setting of end of life palliative care, oftentimes that is cancer related pain. And opioids have been shown to be more beneficial than other types of analgesics. And the same is true for sickle cell disease. So to speak, the risk benefit profile may be a bit more favored for those patient
Mm.
populations. That being said, you may think, should we be thinking about opioids as like first line for these patient populations? Again, I like to think holistically and think, can we utilize other analgesic modalities first if we can? But
Hmm.
if pain is so severe, or if there are considerations that would prevent the use of other analgesics, such as cardiovascular disease, reduced renal function, or
Mm.
hepatic or liver function, then obviously I may revert to thinking about an opioid first instead of as a second option.
Sure, sure. And I actually have this later in my notes, but I feel like I should have moved it up, and I kind of want to talk about it real quick because we
Yeah.
mentioned both a few times. Can we define palliative care versus end of life care? Like, is there a difference? Are they used interchangeably? Like, let's go ahead and maybe I feel like that might be necessary foundational information.
Yeah, I'm glad you brought that up first because it is very foundational information. So, palliative care is what I like to call, and what many of my colleagues and guidelines like to call, is providing an extra layer of support for a patient living with any type of serious illness. So, I mentioned the types of patients that I see in my clinical practice
Hmm.
is really vast, and so we provide care for patients living with any type of serious illness, and then they can be at any stage of their disease trajectory. So, meaning we may see them the time following a diagnosis of a serious illness, or we may see them later on in their disease trajectory as complications exist, as severity of symptoms may progress more, or if patients just request it. So we kind of see the gamut of where patients may present in the setting of a serious illness. Hospice, on the other hand, which sometimes is viewed as a synonymous or interchangeable term with palliative care, is a medical definition in which a provider would not be surprised if an individual would die in the next 6 months. So it does have that 6 month diagnostic or
Mm.
prognostic indicator. But in my clinical practice, we see patients regardless of their prognosis.
Okay.
We help facilitate referrals to hospice if and when it's appropriate. We facilitate conversations about what hospice is and what patients' viewpoints are about hospice. But this is an important conversation that I like to facilitate with patients and their loved ones when we see them in clinical practice, because sometimes that is the elephant in the room of
Hmm.
what the difference between palliative and end of life care or hospice care is. Because with what is out there in the literature, what's out there in the media, it can be really confusing to tease through.
Yeah, for sure. So it sounds like, I mean, while I guess they could be used interchangeably, we just need to understand that some patients who are receiving palliative care may not be in that end stage prognosis. Like they may not have, they may live for 10 more years or whatever, but
Exactly.
still be receiving palliative care. So,
Right. Yep.
okay. Okay, that's good to kind of clear up. And I think it's important just to note that when we say those, again, end of life care could be receiving palliative care, but just because you're receiving palliative care does not mean you're in end of life, I guess.
Right. And
Okay.
to kind of then
Okay.
segue into what we were talking about before as it relates to selecting opioids is if we suspect that a patient may have a prognosis of many years, we may
Mm,
be more worried about chronic adverse effects of opioids that may
mm-hmm.
precipitate after they've been taking it for several months or even years. So
Mm-hmm.
concerns about hyperalgesia, impact on endocrine function, impact on bone health. Those are some of the things that we do worry about for patients that we may see in disease survivorship or may have been living with a long-standing serious illness in which they've been
Mm-hmm.
prescribed opioids. So my clinical thought process of thinking about whether opioids may or may not be appropriate or what dose is often interrelated to disease prognosis as well.
Yeah, that makes sense because like you said, if they have many, many years, expected left to live, then why jump straight to opioids if it's going to cause more problems down the road? So,
Right.
yeah. Okay, that's great. Okay, so I think we'd be remiss if we didn't talk about just kind of the public health context of opioid use and
Sure.
also just in general, um, that there is I guess, a misunderstanding or a stigma or fear associated with using opioids or prescribing them or, things like that. So let's kind of touch on those for just a little bit. So let's start with um, kind of that misunderstanding of opioids. If you can kind of, I don't know if I've set you up well with a question
Yeah,
there.
no, that's all right.
Okay.
I think that just in the world what we live in with the publicity of the opioid epidemic,
Hmm.
that has created a sense of fear, so to speak,
Hmm.
among many individuals, particularly pharmacists. The Controlled Substance Act says that we have a corresponding responsibility as providers to ensure that we are recognizing that this is an appropriate prescription, appropriate dose, appropriate indication. And opioids really kind of drive home that point. And so it is a core part of a pharmacist's job to have this level of stewardship for any medication, but with the considerations with the opioid epidemic and the media, that can evoke that sense of fear.
Hmm.
Um, Providers also have a similar sense of fear from a prescription perspective as well, of thinking, is this an appropriate indication for prescribing opioids? And particularly, this can be a really great opportunity for engaging pharmacists in the ambulatory care setting or the acute care setting if you're facilitating a hospital discharge, for example, to determine if as it relates to that corresponding responsibility, working right there with the provider, if this is an
Hmm.
appropriate indication, dosing's appropriate, et cetera. And then understandably, patients, when they hear the word opioid, it may cause their eyebrows to raise a little
Yep.
bit, particularly calling out particular opioids as well, morphine, fentanyl. Those could be some concerning medications for
Hmm.
patients. And
Hmm.
sometimes fears that we need to learn a little bit more about in clinical practice. So I encourage pharmacists and providers in general, if they can pick up on some of those nonverbal cues of patients seeming a little bit concerned about a particular opioid or just hearing the word opioid, that particularly in the patient population we're talking about today, that we are providing reassurance that these medications are being used for a legitimate medical purpose and that concerns surrounding things like addiction, tolerance, and
Hmm.
dependence are things that we assess regularly as pharmacists, as regardless of clinical practice setting and as providers.
Yeah.
And those three terms that I used, addiction, tolerance, and dependence, like sometimes that can be like a good thing to
Review.
define to
Hmm.
patients
Hmm.
because there is a difference, and sometimes those terms are used interchangeably.
Yeah. And I think it's important, to not be dismissive of patients' fears or concerns because It's real. I mean, just my sister just underwent a pretty major surgery. She had a kidney removed, and
Oh,
and she, texted me and was like, I'm having to take my opioid pill twice a day. Is that okay?" And I'm like, "Sis, you just had a kidney removed.
just
Like,
had your, yeah.
I think that's okay for a while. Like, we're not taught." She's like, "I just don't want to become addicted, or I don't want to become dependent upon it, or whatever." And I'm like,
Hmm.
so I think that fear is real in patients. Like, they really do. They hear it in the media. They hear it, the concerns or the troubles surrounding, the opioid epidemic. So
Hmm.
um, I think it's important for pharmacists to not be dismissive, but like you said, take that opportunity to define, to further talk, and to further have the discussion so that the patient is well informed and understands exactly, what's going on with their care at the moment. So,
Yeah. And I think to build upon that just a little bit further is to define what is realistic pain expectation. So, you gave the
hmm
example with your sister, following a surgery, pain may improve in the coming days to weeks. But if we have a
hmm
patient living with an inoperable tumor, that may be something that may be persisting for the rest of their life. And
right.
is that a sense of permission to use a medication like an opioid, for example, to help them do their activities of daily living, do the things in life that matter most to them.
hmm
But then also on the flip side, of educating, if some degree of pain is going to be something that they're going to potentially live with for months, years, or indefinitely, what's realistic for pain? Our goal is always to improve function, to
hmm
enhance quality of life, but that goal may not be to get pain down to an absolute zero. And
Zero.
so that is another good point for pharmacists, regardless of their practice setting, is to explore with patients what their understanding of their pain goals are.
hmm
It could be a point of pharmacists to educate about what is realistic expectation, or it can be a point for a pharmacist to be an advocate for the patient, to follow up with a provider to say, what is reasonable.
I love that. Yeah, yeah. So not only reviewing expectations, but sometimes setting them and helping to collaborate to set them. So yeah,
Yeah.
that's great.
And the
Um,
earlier you do that, the more successful sometimes
mhm.
long-term outcomes can be.
Oh, for sure, because
Hmm.
it's almost like getting everybody on the same page before you start writing it. So yeah,
Right.
yeah, for sure. So we've kind of touched on the role of the pharmacist in this space, and obviously we're there for safe and appropriate use of all medications, specifically in this instance. And it's, I want to be sure that we're also not being dismissive, that it's okay for you as a pharmacist to have a little concern or fear when you see an opioid prescription come across,
Right.
for your approval or whatever.
Hmm.
So it's okay to have that, and it's okay to take a second look and to pause and to double check and whatever. But one thing that I wanted to talk about was, well, and actually I'm going to get to it later, so I want to save that. But I do want to bring in patients and because sometimes who's involved are their families or their caregivers. So I want to be
Hmm.
sure that we spend time on that. But I do have another point on that. So let's jump into we've touched on this a little bit, but let's reiterate, what are those appropriate indications for using opioids in the palliative care setting? And, as you mentioned, it differs for patients. And so we're going to have to start
Hmm.
asking questions, and it's also going to be layered. But then I guess, how do we determine if some of these are exempt from some of those guidelines? How do we determine dosing, and how do we determine first line? And, do you jump right to a fentanyl patch, or do you try a 5 milligram oxycodone first? Or, like, what are the, how do we do that if we don't really have the guidelines to go off of, I guess, if that's what I'm saying. Maybe
Yeah.
I'm
No,
misrepresenting that. So,
makes sense. Lots to unpack there, but I think just generally speaking is that analgesic regimens, including opioids, really need to be individualized as much as possible according
mm,
to patient-specific factors. What is challenging, especially for our pharmacists practicing in the community space, is that there is missing information to help determine appropriateness of indication and dosing. So yes, if you see a prescription for a transdermal fentanyl patch come across for a patient that you've checked the prescription drug monitoring program, you've checked previous prescriptions, and you don't see any indication that the patient has been on opioids historically, yeah, that should definitely kind of raise an alert in your mind and want to ask further questions.
Mm.
But I would definitely encourage, particularly pharmacists that are being available at the point of prescribing with providers, to help put in information to help our community pharmacists as they facilitate that care transition.
Mm.
So making sure that there are diagnosis codes on prescriptions. In Iowa, you don't have to have a diagnosis code on a prescription, believe it or not. So that is something I would strongly encourage providers to have.
I think that's
And
true in a lot of states. I
yeah.
mean, I don't think that many of them require it. So
Mhm.
yeah, that's a great point though. I love that making sure that they're on there, especially if you're a pharmacist in another
Right.
setting,
Yeah.
because that could translate to easier discernment from community
Right.
pharmacists. Yeah.
So,
Yeah.
for example, like for our patients that are living with cancer related pain in my clinical practice, I always make sure that there is cancer related pain as a diagnosis code,
Mm.
and then followed by palliative care is also a diagnosis code. So, I always make
Mm.
sure there's two diagnosis codes on the prescription.
Yeah.
And then, if there's any information that's like relevant to pass off that you think that a provider may not, or excuse me, rather, a pharmacist may not have by doing a prescription drug monitoring check, oftentimes a lot of electronic prescribing systems have opportunity to put like notes in a
Notes.
prescription. And
Hmm.
so having that extra note, can save a phone call,
Yeah.
which may be hours on the phone, maybe even more than hours,
Hmm.
continuing to the next day, delaying care to patients,
Yep.
or being proactive, contacting the pharmacist at the dispensing pharmacy. Faxing information if applicable. But in absence of that information, I just really encourage community pharmacists. I recognize that there's so much that impacts their busy day, to take a
Mm.
moment and pause and ask patients openly, tell me a little bit about what this medication's prescribed for you for. We
Hmm.
use it for lots of different things, but could you tell me a little bit about it?
Yeah.
And, that kind of gets to the underlying premise of that pharmacists have a corresponding responsibility. And if you ask with a sense of openness and humanness, really, and
Hmm.
clinical curiosity and
Genuine.
concern,
Hmm.
yeah,
Hmm.
that patients may be willing to open up with you and share what's going on, rather of it coming across as being somewhat of a punitive, record keeping,
Or
micromanaging.
accusatory,
Yes,
or yeah. Hmm.
accusatory. Yes.
Hmm. Yeah. Yeah. No, that's a great point. I love also the fact that that you're basically advocating and encouraging other pharmacists to support other pharmacists, because
Yes.
that's one of the beauties of our profession, is that we can work in 4,000 different settings, and but being able to identify and recognize that, hey, this might be a point of issue or a pain point or barrier for another pharmacist down the road who's
Yeah.
filling this or dispensing this to the patient. So I love that idea of making sure that you are being complete with putting the diagnosis codes on there, adding some notes, touching base with them if you feel the need to. So that's
Yeah.
really good advice.
Yeah.
Because
Like I'll
again,
use, oh, sorry, go ahead.
I was just going to say, because again, that, the dispensing pharmacist ultimately is the one that is making that final decision. So any information that can be shared with them is helpful. So yeah,
Yeah.
that's a great point.
So, I mean, I'll give a perfect example. So, I use that transdermal fentanyl prescription that
Mhm.
may come through to a community pharmacist. If there is an opportunity to put a note in the prescription that the patient has been admitted in the hospital for the last 10 days and they've been taking 60 oral morphine equivalents for the last 7 days, which is the requirement for starting a transdermal fentanyl patch,
Mhm.
that is kind of, the click in the verifying pharmacist's
Yep.
mind to be like, okay, then this is appropriate indication, and it saves
Mhm.
a phone call.
Yeah, no, it's great. I love pointing that out. That's really good. So I think we did this before. This is where I had my note to distinguish between palliative care versus end of life care. So I'm glad we did that earlier. I think that set the stage really well. Here's where I want to get into patients and caregivers, because
Hmm.
I feel like oftentimes it may be our patients, as you mentioned earlier when we were talking before we started recording. some of these patients who are receiving this care from us may not be the best point of giving historical relevance or something like
Right.
that. So there may be a caregiver involved. What sort of level of complexity does that add to the mix when we're taking care of these patients?
Yeah, that's a really great point because we definitely want to uh, appreciate patient autonomy as much as possible,
Sure.
but recognize that there could be a number of different factors that are interfering with that. And so, if a patient does have a trusted caregiver that is a part of their at home care team, that's a really huge asset for their care. So, one thing that like I may be providing particular education to caregivers about. And my role again is in ambulatory care, but I think that pharmacists, regardless of their care setting, can do this. Is to encourage patients and caregivers to keep a log of how frequently they may be taking as needed opioid
Mm.
medications.
Mm-hmm.
That's important for us calculating daily oral morphine equivalents and helping with us facilitating safe dose adjustments. And so, whether it's an app in your phone, whether it is a notebook, jotting things down,
Mm.
I would encourage both patients and caregivers to take an active role in doing that, of recording when PRN doses are given.
Mm.
Because that can help us adjust both short acting or PRN doses, but then also the consideration of starting a long acting opioid as well and adjusting the dose of long acting opioids. So that would be a consideration.
Yeah, and in addition to, it being at the ambulatory care meeting or, appointment that you're mentioning, that's when you encourage it, the dispensing pharmacist could also encourage that as well, because
100%.
close that loop. So it's, that's more that's a task that others could take on as well. So yeah.
Hmm. Yeah, absolutely. I think the other piece is from the perspective of kind of like a public health opioid safety
Hmm.
consideration,
Hmm.
is that when we dispense opioids to patients or prescribe opioids to patients, um, there's always a concern that they may get in the hands of someone
Sure.
that does not have a legitimate medical purpose for them as well, or,
Hmm.
an accidental situation that may
Hmm.
have terrible consequences. So, in my clinical practice, we dispense naloxone for every patient in which we, or I should say, we prescribe naloxone for every patient in which we send an opioid prescription, regardless of whatever their dose is.
Hmm.
Just because of, as I mentioned, the public health and the safety considerations, not just for the
Yeah,
patient, but for others in the home. And that's for
sure.
patients at any stage of a serious illness, even towards end of life considerations as well. So making sure that caregivers know how to use naloxone,
Mm.
because it would not be something that a patient would administer to themselves.
Right.
Um, Many states, and I actually think almost all states, have a standing order
Hmm.
regarding naloxone dispensing. And so, even in absence of a prescription, naloxone can be dispensed to a patient. So, if you are in the community pharmacy setting and you're involved with community pharmacy protocols, maybe developing a protocol of thinking about when you would want to dispense naloxone to a patient.
Yeah.
If it is a certain diagnosis code, if it's a certain opioid dose. So
Hmm.
then that is just something that is routine in your clinical practice instead of awaiting for a patient to request it, because there's a possibility that they may not be aware of what naloxone is or what an
Sure.
individual patient's risk is for
Yeah.
opioid overdose or respiratory depression.
That's a really good call, Lauren. I appreciate you bringing that up. I feel like that was even missed in my initial notes, but I think that naloxone should be in the midst of a conversation anytime opioids
Yeah.
are in the midst of a conversation. So, and that, recently talking with a colleague that did another course for us, and um, she was very proactive and set up a system, a workflow, kind of interplayed with their workflow when a prescription was being dispensed, an opioid prescription was being dispensed. It flagged one of the pharmacists to immediately have the conversations about naloxone. And so they were
That's
able,
great.
it was ridiculous numbers, like so good as far as like getting more of the naloxone doses into the right hands. And I think she even had a data on saved, lives basically, because like actual use of naloxone and how the fact that they got it into the right hands. And so, yes, great point. Thanks for them bringing that up. I think it's really important that that is a conversation that's had anytime that opioids are being dispensed. So,
Hmm.
um, okay, so let's talk a little bit about, we touched on this too as well, but just to kind of reiterate, one of the other opportunities for pharmacists is to be sure that we're collaborating with the other members of the healthcare team,
Hmm.
specifically with the prescribers. And as you mentioned, making sure that prescriptions are have the diagnosis codes, making sure that notes are going there that are appropriate. And if you're in the dispensing side, then, if you don't have the luxury of someone giving you those notes or that heads up, it could be the case that a phone call is necessary, or, just a quick touch base with the prescriber to make sure. I think that can often clear up some confusion. And
Yeah,
as you
and
mentioned too, talking with the patient directly, like that can also clear up confusion. So,
right. And
yep.
I'll just add, checking the prescription drug monitoring program for your
Yes, for
state and
sure.
a neighboring state is also really, really important to
Yes.
gather relevant background information, regardless of your clinical practice setting as a pharmacist.
Yes. And I think, I love that point as well. Like thinking about, if you think oftentimes patients um, who have cancer, they may be seeking treatment from another state. It could be
Right.
that they're going to a specialist that's somewhere else. So I think that's something really important to note as well, and again, that's where proper communication with the patient could bring that up and say, oh, well, I've been staying in X state for 6 months, and that's where I was treated with this. So this
Hmm.
this is now the next move. I'm finally back home or whatever. So
Right.
yeah, great point. All right, so some of the challenges, we touched on these, but just briefly reiterating them, there is a stigma and some fear surrounding opioid use, not only with dispensing it, not only with prescribing it, but also from the patient perspective of, accepting it and taking it. And I think we touched on well, kind of how to communicate and to properly overcome that fear and how to address the questions and the concerns that patients may have.
Hmm.
And then I think we touched on assessing some prescriptions that appear higher than usual without undermining care goals. So that's a role that we have to do. And we talked about that, asking the right questions, talking with the patients, picking up the phone if necessary, and speaking with the prescriber. And then is there anything else from a compliance or regulatory perspective that you want to bring in when dealing with opioid prescriptions?
Yeah. So one piece that I'll add from the perspective of, you're doing your best to reach out to a provider and collaborate, and you're not able to get a hold of them, and the patient's
Mm,
waiting in your pharmacy. What do you do?
mm,
Many states have laws about doing partial fills of opioids. So thinking about, is there a possibility that I can do a partial fill of this prescription until I get a little bit more information, recognizing that if I prevent the patient from getting access to this necessary medication, that this may create some undue suffering. But then it also allows for a sense of safety for me to gather more
sure.
information before dispensing the rest. So that would be something I would encourage you to think about, and even to think about like developing community pharmacy policies
Protocols.
surrounding.
Yeah.
Yes, yes.
Hmm.
So that's an important consideration.
I think
Um,
that's great. And I,
yeah.
I, I would encourage everyone, if you're unsure of what your state laws are about that, to check with your board of pharmacy and see what those are. But that's a very, very great point. Thank you.
Yeah, absolutely. And then also, I've learned that like different states have different laws as it relates to dispensing day supplies of opioids. Sometimes I've noticed this as being like an insurance or third party limitation, that they may not allow for initial fill more than 7 days,
Hmm.
whether it's a short acting or long acting opioid. Some stores have policies of that. And then even some states have policies of that as well. So recognizing, what may be some situations where the 7 day supply rule should not apply, like if there's a
Hmm.
specific diagnosis code, for example. And if that is above the level of like your individual pharmacy, advocating at a corporate level or even at a
Hmm.
state level for opportunities for exceptions to those rules.
Yeah, that's great. Great. All great points. And I think all good things for pharmacists in multiple practice settings to think about, because I think a lot of those, it's not just in the dispensing and it's not just on the prescribing. There's other places where pharmacists are interacting with patients and can um, note these changes or be advocates on the patient's behalf. So those are
Mhm.
all great points. Um, Great discussion, Lauren. This has been so helpful, and I feel like it even clears up some of the confusion that I think everyone has. I know I can speak for sure that I have on palliative care versus end of life care, and when do we start opioids? Do we jump right to them? What to expect when you're seeing those come across in the dispensing form. So really good stuff. Is there anything that you feel like you wanted to add that we haven't touched on?
Um, I have a couple of resources. Did you want me to share those
That would
now?
be
Or okay,
fantastic. Yeah,
great.
that'd be great.
So for anyone who may have questions about opioid calculations, which I mean that could be a whole podcast in and
That's
of
a whole,
itself.
that could be a 3-hour podcast.
Absolutely. I would encourage you to check out the book Demystifying Opioid Calculations by Dr. Lynn McPherson. She's a pharmacist, a hospice pharmacist from the University of Maryland. She kind of is the expert in this area. So I would encourage you to check out her book. There's excerpts of it online that you can get for free, but if you want the full book, you can either purchase that through ASHP or ACCP. The other consideration is there is a free palliative care kind of resource, I should say repository. It's called the Fast Facts through Palliative Care Network of Wisconsin. They have what really are, they're called Fast Facts, and there are hundreds of them, and they are concise, practical, peer-reviewed summaries ranging about things from symptom, pain, medication management, deprescribing, goals of care conversations, end of life considerations. So I'd encourage you to bookmark that. As that can be really helpful to get some necessary background information that's also free as well.
Yeah, that's great. Very good. Thank you for sharing those. So one thing that I like to do before I wrap up each episode is the name of our podcast. It's Game Changer. So Lauren, what is the game changer here? What do you feel like is the big take home that we want our listeners to go away with today?
Yeah, absolutely. I think wherever you can facilitate care transitions about opioids, really do your best to communicate that, whether that's through diagnosis codes, whether that's collaborating with a pharmacist in another care setting, whether that's providing education to a provider about what could be something that a community pharmacist calls back and has a question about. Really do your best to think proactively about providing care transitions and recognize where there may be data that's missing that can impact the ability for a patient to access their needed opioid medication.
Yeah, that's great. And because it's not all about, we think about, well, that's holding up us dispensing it or that's holding up whatever, but ultimately it's holding up the patient getting the medication that was intended for them and that they need. And that could change, like you said, activities and quality of life and whatnot. So, and cause undue pain and harm. So, yeah, so I think that's a great point. Really, really great point. Lots of nuggets from today, but I think that is one of my favorites in the sense of think about ways in which basically your job could be easier and then advocate for those changes. I mean,
Right.
that's really what it is. So, and ultimately it will help the patient get the care and medication that they need. So, well, Lauren, thank you so much. As always, it's a pleasure and really appreciate giving us your time today for today's episode.
Yeah, thank you so much for having me, Josh.
Of course. If you're a CE Plan subscriber, be sure to claim your CE credit for this episode of Game Changers by logging in at ceimpact.com. And as always, have a great week and keep learning. I can't wait to dig into another game-changing topic with you all next week.